Welcome to this podcast exploring the science and innovation behind Eustachian tube dysfunction and its management in the context of chronic otitis media. I'm your host, Dr. Ashour. Today we'll be speaking with Dr. Muaaz Tarabichi, widely regarded as the father of endoscopic ear surgery. His work has helped redefine our anatomical understanding and open new therapeutic avenues for chronic otitis media and Eustachian tube dysfunction. In this episode, we'll cover how endoscopy changed our understanding of Eustachian tube anatomy, when and how to intervene in the context of chronic otitis media, and what the future might hold for our field. We'll conclude with some clinical pearls and practical takeaways you can use in your own practice. Dr. Tarabichi, thank you for joining us. It's a real pleasure to have you.
Thank you very much, Dr. Baher. It's a pleasure and an honor to be with you this evening.
Let's start by asking, before endoscopes became routine in otology, how did we traditionally think about the Eustachian tube? And what changed when we started using endoscopes?
So, as you could see, I have a lot of gray hair, and I could look back at my residency time. And I remember my main teacher in otology telling me, stay away from the Eustachian tube. It's just a dangerous area. You don't want to be there. You get into complications. And I think for much of my career, this has been the case. And somehow, we think of ourselves as innovative and stuff, but really very indoctrinated people. So I have to tell you that I have probably for the first 30 years of my career, I listened attentively to my teacher and not really thinking about the Eustachian tube. And to think that, looking back at this issue now, it really is surprising that, we all, one way or another, think that the Eustachian tube is at the core of a chronic ear disease. And somehow we basically abandoned it. We thought that, I think surgeons in general, they like what they see. If you have access, they want to go for it. If they don't have access, they tend to forget about it. We really don't care about the pathophysiology of the process. We just care about what we could do in terms of intervening and changing the course of the disease process that we're facing.
Yeah, we always kind of thought of it as like an untouchable area or something we can't access, or maybe it's too dangerous to access. Until I think we actually started looking properly with the endoscope into the protympanum and realizing that, the traditional anatomy that we were taught might not be perfectly correct.
And even looking at the protympanum, this is one of the other things that I've noticed about my journey with the endoscope, that I swear for the first 15 years of looking with the endoscope, I thought of the endoscope as, let's say you have a perforation, I fix a perforation, of course you don't, I take it out. But I never, for first 15 years of my career, thought about looking at the Eustachian tube, which, if you really ask me, is probably, and I say probably because of many reasons that we might come to, probably at the core of chronic ear disease. So again, goes back to with time, I'm thinking, again, we as doctors and surgeons, we think of ourselves as very sophisticated, very innovative, but honestly, again, we're very, very indoctrinated group of people in general.
Yeah, I think it has a lot to do with respect to our teachers and our professors, and also quite a bit of backlash that you can get if you deviate from the norms.
Absolutely.
That are, indoctrinated, as you said.
A lot of group thinking.
Yeah, peer pressure as well. If you start to deviate, sometimes the attack can be quite vicious. So, let's look at this image here. This is a histological slide with some 3D reconstructions of important anatomical structures of the middle ear and the inner ear. We can see in this image here the protympanic or the middle ear opening of the Eustachian tube, and above it we can see a false passage. How often do we encounter this type of false passage in the middle ear?
So basically, again, over the last 10 years or so, I started really looking at the protympanum with a 30-degree endoscope. And, all of a sudden I'm seeing things that I've never sort of thought about and experiencing anatomy that I've never really appreciated. So this is basically something that I have done myself. This is using a very common, I think you know it, it's a 3D, I think it's called 3D temporal bone. It's done by Harvard.
Yeah.
And Mass Eye Fermi. So basically, they basically digitized the histologic specimen. So I localized, just for orientation, I localized the area of the carotid artery, the cochlea. So you could see the ear canal, the eardrum, and the protympanum. And the protympanum is a very, very variable structure. And Danielle Marchioni had done very, very good work, as usual, on the anatomy, endoscopic anatomy of the ear. And like one of his main big themes is that in the protympanum you could either have a rectangular structure or cavity, or you could have a triangular cavity. So when you have very limited pneumatization, you have a triangular space, and basically you really don't have any false passages or blind passages, and you basically had immediately...
It's very straightforward, and it's one opening and no confusion there. How about when you have excessive pneumatization?
Well, you have a lot of pneumatization, then you have a lot of false passages. But the main two structures of the protympanum is basically the carotid artery and the tensor tympani muscle. So the tensor tympani muscle is your guide to the opening of the Eustachian tube. If you follow the tensor tympani muscle, you're going to get the opening of the Eustachian tube. If you start looking at it and you're thinking, this is the opening or this is the opening, you get lost when you have a significant pneumatization. And the other thing about the protympanum is that most of us think that, the whole protympanum is occupied by its carotid artery. But really, the carotid artery basically intersect rather than goes along the axis of the protympanum. So it's almost like it comes at a right angle to the protympanum. So you get a bit of protympanum, you get the carotid artery, then you get more protympanum, and then you get the fibrocartilaginous Eustachian tube.
So I'd just like to talk a little bit about this axial CT, which apparently shows as if the carotid artery is parallel and adjacent to the whole course of the Eustachian tube. And I think that's not a real fact, that they actually diverge from each other. Is that correct?
Yeah, absolutely. And this is going back to my point about us surgeons being very simple people, that we all visualize are we used to looking at the CT scan with an axial cut. But really, the Eustachian tube is not an axial structure. It basically goes down about 30 degrees from the horizontal plane. So what happens is that if you really want to have a good picture of the relationship of the carotid artery with the Eustachian tube, you need to angle your section in a significant way. And then what you will see is that you'll see that, again, the carotid artery almost transects the protympanum, or what we used to call the bony segment of the Eustachian tube, almost at a right angle. So you get, again, protympanum, bit of protympanum, carotid artery, and then you get more protympanum, and then you get the fibrocartilaginous Eustachian tube. And this is not a call for people to relax and not worry about the carotid artery, but it just better understanding of the anatomy, which serves us well actually in maintaining safety and providing for effective treatment for our patients.
So this angled CT view is the basis for the CT Valsalva, correct? I mean, that's the cuts that you're looking for to see the whole length of the Eustachian tube while the patient performs a Valsalva maneuver.
So Valsalva CT is something that I've described, published in the Laryngoscope, I think 2014 and stuff like that. But I just want to say that I came to this area basically with certain assumptions about everything about the Eustachian tube. And I always like to say is that I found much of my assumptions are wrong. So a significant part of sort of the things that helped me better understand the problems and the anatomy and the physiology we're dealing with is first endoscopic ear surgery, the ability to look into the area of the protympanum with angled endoscope. And the second one is Valsalva CT. So, as everybody else in this field, again, I had certain preconceived idea. And the Valsalva CT, just because it allowed me to see the Eustachian tube, it allowed me to, and I've always been the person. I always joke around is that when I go to the radiology department, I really don't want to talk to the radiologist. I try to avoid any eye contact because I know they're going to be offering me help and stuff, and I really honestly don't need their help. I think for us, as you probably have the same feeling as ear surgeons, we have a much better understanding of the anatomy of the ear cavity.
I rarely read the reports. I like to see the films.
It confuses you. And I am in a way good into computers. So I just issue of reconstruction and stuff. I really played with a lot, like with the stations in the and even I got at one time when I was working at a different institution, I got them to get me one of those big terminals up in the clinic area so I could access the data and manipulate it on my way. So this is again the time that I started to understand what I'm talking about now. Is that what you see here is not the real situation. And the Valsalva CT, I guess, of course, I think there might be, and I say might be, I'm not too sure, there might be a clinical application to it. But it really taught me a lot about the Eustachian tube and
where the possible narrowings are.
Exactly. And I think it's almost like eye-opening, like certain things that the Valsalva CT had taught me. It's sometimes just honestly, no matter what you read, it doesn't stick. Sometimes you really need to have your hat on to see it, manipulate things and stuff like that, and then things start sinking in, start to have a better understanding of the...
And this is what directed your idea to actually dilate the Eustachian tube through the transtympanic route, because you felt that the narrowing was most likely closer to the ear than it was to the nasopharynx.
So I want to sort of, again, looking back at the last 10 years of my career, when I started this process of looking at the Eustachian tube, I really was of the firm belief that there is an anatomic issue at the heart of our problems. The reason I was thinking like this is basically, again, going back to us being simple people looking at our surgeons. Basically, we like to deal with anatomical issues. We don't like to deal with biological issues. So I have to say that, like, over the last 10 years, I'm inclined more. I think there's definitely anatomic issues. I think in a significant subgroup of our patients, there is a definite anatomic issues. And I would put these anatomic issues in one of two ways. First, we're talking about now chronic ear disease. We're talking about the draining ears. We're talking about colostoma, retraction, stuff like that. I'm not talking about failure to equalize and having barotrauma, stuff like that. So what I feel. So I'm more and more I'm thinking now there are definite anatomic issues, but I'm also thinking that there's a significant number of patients that have some other
functional issues,
biologics, whatever,
inflammatory issues.
Exactly. So in terms of the anatomic issue, a significant subgroup is obstructive, and the reason I know that is probably something that we're going to talk about later, which is the opening pressure of the Eustachian tube. So I've been measuring the opening pressure of Eustachian tube during my surgery. The other thing that, if you listen to this podcast and you're thinking, what message can I pick up? Patulous Eustachian tube. Patulous Eustachian tube does cause chronic ear surgery, severe retraction. You gotta think about that. Because of the repeated sniffing, or what? Exactly. How is the mechanism? I have to tell you, the first time I heard about sniffing was in a meeting. I think it was in Dublin, somewhere like that. And I almost laughed at it. I thought, what is it talking about? Sniffing? You're going to sniff and you're going to get retraction? But it's really real. It does exist. And I remember the one patient, specifically a pediatric patient, that really opened up my eyes to this. And one thing I tell people, one little trick that you could use to know these patients is that ask them to do a Valsalva. And you will notice that after they do the Valsalva, they go like, and you say, why are you doing this? And they will tell you they cannot speak until they do it because they're so bothered by the autophony. You observe that, you'll be able to pick up on these patients.
How common do you think these patients are?
I think in terms of the chronic ear population, I think it's about 5%.
But it's really important to pick them up because if you dilate a patient like that, you're going to make things a lot worse.
Absolutely.
So when you first started using endoscopes, what surprised you the most anatomically or clinically? What thing that changed the way you viewed your practice with the endoscopes?
We're talking about in general or in regard to Eustachian?
Well, in regard to the Eustachian tube.
So in regard to Eustachian tube, the first thing that I want to emphasize is that if you're just like an old school ear surgeon and you're just interested in eradicating disease, you gotta look at the protympanum. Because a lot of times there's a lot of things hiding in there. I can't tell you how many times I thought that there's no left coast, that there's no colostoma. It's even surprising feelings. Like 2 or 3 times I saw a small tympanostomy tube sitting in the protympanum, hidden from
supratubular recess.
Exactly.
These areas. And you can't see those with the microscope unless you significantly remove.
Even with a regular endoscope, you cannot see. You have to make an effort to look with a 30-degree endoscope at this area. So I think it's unforgivable given the level of technology and what we have, the tools that we have in our hands for us to say, well, we're not going to look at this area. It just, especially given the fact that, that this is the most upstream area of the ventilation system. So I think it is something that, and I always say one of the biggest things about the endoscope is that it moves us forward in terms of our access. So we started out with a microscope, which is all about mastoid. Big cavity, nice cavity, you go in and you see, but you're so far posterior to everything that's important. Yeah. First you have posterior to the mesotympanum, then posterior to the retrotympanum, and posterior to the protympanum, the Eustachian tube. We're leaving all these structures, and again, that is our natural inclination as surgeons not to worry about things we don't see.
It was an access issue.
Exactly, and to worry too much about things that we can see.
Yeah. So moving on to the next bit is, so when and how do we intervene with the Eustachian tube in the context of chronic otitis media?
I think you have to, first, I think nobody has the absolute sort of truth on this. I think we're just starting to explore this area, and I think we have a long way to go to have the data-driven decision making in this area. So I started because, again, the first thing that motivated me to look at or to do something is that when I was looking at the protympanum, and I saw a lot of obstructions with the endoscope. So that's the first step for me to get engaged in this. And then I started doing some balloon dilatation from the ear side, transtympanic balloon dilatation. And of course, I started with the balloon dilatation after I heard Holger talking about balloon dilatation, but he was talking from the other end of the Eustachian tube. I was a bit frustrated with the traditional balloon dilatation that I felt in many cases It did not work well, or it did not do much. And that's why I was like more further pushed into the transtympanic balloon dilatation. So again, as time passes, I'm getting to understand that there might be a role for these two different things. And but the initial instigator of me doing balloon dilatation is because I was seeing a lot of obstruction from the ear side with the 30-degree angles in the area of the protympany.
Okay. So, Dr. Muaaz, I'd like you to talk to us a little bit about these images here that were published in 2016, I believe, in the clinics. And this is the anatomy of the protympanum. If you could just give us a tour and what your thoughts are with the endoscopic views that we can see in front of us.
So what I was demonstrating with these two images is, again, the fact that when you have a significant pneumatization of the protympanum, it's very, very hard for you to tell, if you're not guided by certain principles, to tell where's the opening of the Eustachian tube. So the first thing I want to say is that you have to use a 30-degree scope to visualize that area of the protympanum well and to recognize where's the opening of the Eustachian tube. The second thing, you have to use a 3mm 30-degree endoscope.
To get between the malleus and the annulus, the anterior annulus.
I mean, you don't actually, I don't know if you want to squeeze your scope in there, but you certainly could advance it a lot more than a 4mm endoscope. And if you're using a 4mm, even angled endoscope, sometimes you get to see, but I would say in general, you don't get to see the areas that we want to talk about. And the image on the left side is basically you're introducing, this is a 30-degree actually endoscope, but you look at, this is, you see the handle of the malleus, and this is the right ear, and you see like one area where you think it's a Eustachian tube or possible Eustachian tube, the PET. But if you really push further, you recognize that what you're seeing is just a line pouch, basically, or false passage, and the Eustachian tube is further laterally. So this second image is just to demonstrate, again, this is a very well pneumatized, again, rectangular space, and you could see a lot of structures, and again, Danielle have a habit of calling everything with a name, so you could see some of the names out there.
Subtensor recess,
yeah.
That's a new one.
But my point here is that if you want to look at the Eustachian tube opening, follow the tensor tympani. You see it on the image on the left side or the right side, I don't know. So you can see that it guides you to the star, the white star, or you have the opening of the Eustachian tube. So the tensor tympani really inserts almost on the upper part of the fibrocartilaginous Eustachian tube.
So this is an image of a 3D reconstruction of the mastoid middle ear and Eustachian tube. What has this type of reconstruction taught us about the anatomy of the middle ear?
So going back to what the Valsalva CT taught me about the Eustachian tube, this is one of the first things I did. This is a 3D reconstruction. You could do it on any workstation in the radiology department. And when I was very impressed by this image that I created, and the points that I want to make is that first thing that you've noticed is that the distal nasopharyngeal end of the Eustachian tube is big. That's the only comment that you could say about it. Anatomically, I'm talking about. It's almost like a pocket, and that really is an isthmus or the narrow segment. It's basically the narrow segment in the whole air cell system of the temple bone, and you can see that red line that basically defines the epitympanic diaphragm, which is really separating the mastoid area and much of the attic from the mesotympanum, and that's another area of possible obstruction. And I think this basically, if you have a failure of ventilation, my feeling is that, and I emphasize the word feeling because it's not driven by data, this is driven by sort of a general impression and clinical practice, is that these two areas are the areas where you could have a sites of possible obstruction, failure of ventilation. So when you have a failure of ventilation obstruction in the isthmus area, you have a general chronic otitis media that involves the mesotympanum, mastoid, attic, all the air cell system almost. And when you have a failure at the area of the epithelmanic diaphragm, where you see this line, you have the selective disease process, where you have a normal mesotympanum and you have attic retraction and atticocytoma.
Okay. So now that you've given us an idea of the current practice and the current understanding, how do you see the future in this field of stake-in tube dysfunction and endoscopic ear surgery over the next decade? How do you see it develop?
I think the first thing is that once you deliver access, you create a lot of choice. So I think once we have access into this area, we're going to be a lot more inclined to first understand what's going on and do something about it. And this is on the front of, again, anatomy. Because as surgeons, really, this is all what we can do, is we could change the anatomy in such a way that we improve or we address the pathophysiologic process. I think in general, it's going to be the same sort of, if you look at what happens with endoscopic sinus surgery, is that initially, it's just infection, we're going to open up the sinuses, then no, there's inflammatory disease, but we're still going to open up the sinuses, then no, even if you open up the sinuses, this inflammatory disease is not responding, so you give biologics. I don't know what is going to end up, but I think there is, so now we're looking at, for example, sinus surgery. We know we could help significant number of our patients by addressing the anatomic issues without doing anything else. And we've learned how to understand that we're dealing on a very heterogeneous disease process. And now that we can see, we could make a better diagnosis. And I think we're going to also get to the recognition that we're in substantial number of our patients, there is a biological
underlying allergic component, IgE driven, so biologics might have a role in these patients.
Sure. I mean, I think you pointed out that before, and I agree with that, is that I've seen quite a few patients with allergic fungal sinusitis. They have middle ear disease, and the moment you start them on biologics, the middle ear disease just disappears. And
those thick effusions, very tenacious effusions, they kind of clear up.
By the way, when you put tympanostomy tubes, you have a hell of a time because sucking the patient, those are the patients. It ends up being a very frustrating experience for you and for the patient. So I don't know but I think this is the same issue, that first so access can drive better diagnosis and understanding, and it's going to drive better interventions, whether surgical interventions or medical interventions.
Where do you feel the technology is going with endoscopes, miniaturization, robotics, navigation? Do you think these things will have a role in this particular issue?
I try not to, I've seen different kinds of endoscopes and stuff like that. I haven't seen anything revolutionary, honestly. Everything that I saw, honestly, does not work. I think, to me, is a wedding of endoscope to localization and image-driven surgery could work very well in our area. In the ear, and I think we have to use the access also from the nasopharynx. I think this is a huge access that we're gonna try to use in the future. And I think also, there's a lot of technology that we could introduce into the Eustachian tube to better understand what's going on. Again, talking about the biologic issues and stuff like that, or what's going on in the Eustachian tube itself.
How about the idea of stenting the Eustachian tube with drug-eluting stents and this kind of management? How do you feel about that?
I think again, in our area, in ENT in general, there's a huge role for sort of local treatments or delivering medication locally into these structures, because we have access. It's not like in other specialties. And I think a lot of times you see how the local treatment really far exceeds the success of systemic treatments, just because I think you could deliver medication directly in high concentration and stuff like that. So I think that there might be a role for something eluting medication. I think I think basically the main advantage we have nowadays is the issue of access. So once we get there, there's really no limits to what we can do, and limits for improving understanding, and there's no limits for what we can do. And our problem in medicine and surgery in general is that we have a lot of toys. Again, we have very limited understanding of. So in terms of development of toys, we're going to develop toys, but
do they work or not? That's the question.
That's a story.
Yeah. And also, I think an exciting thing is the actual development of nanoparticle medications that can maybe go through the tympanic membrane and reach the Eustachian tube possibly in the future.
Yeah, and my kids are in surgery and medicine, and I always tell them, you could see that these smart guys that work in the labs, they're going to change our lives, not in a good way.
Put us out of business, probably.
Yeah, put us in. You could, and now all of a sudden you see all this almost popping up of all these different interventions, medications, stuff like that are wildly effective. So probably this is how it's going to end up: is that we're going to give somebody a pill and the Eustachian tube disease is going to disappear.
For younger surgeons hoping to master endoscopic ear surgery and tackling Eustachian tube dysfunction, what are some tips and tricks that can help accelerate the learning curve?
You gotta think of this as a sort of a long process. You cannot say, okay, well, I'm gonna do it. I have the endoscopic skills and I understand the anatomy. So you gotta relax, take it step by step. Definitely have a hands-on course with cadaver. I think it's almost criminal for any surgeons to do something on live patients before he would practice it on cadaver. And actually at CCE, is one of our major objectives is to have a setup for continuous round-the-clock hands-on courses that people could come and practice almost any time of the year.
And there's a course coming up in April, I believe.
The course coming up in April, but again, our main issue is that we're going to have around every day of the year
a lab where
opportunity for people to come and practice.
That's really great. I'd like to conclude with some clinical pearls. The first one is to use angled endoscopes to assess the protympanum and supratubal recess during tympanoplasty. Hidden anterior disease often drives failure. Number 2, select patients, don't select procedures. Consider Eustachian tube intervention after optimized medical therapy and nasopharyngeal assessment. Anatomy and inflammation patterns should dictate the plan. Number 3, balloon dilation is a tool, not a cure. Match balloon dilation of the Eustachian tube to the patient phenotype. Document preoperative function and endoscopy, and set expectations around recurrence and adjunctive therapies. Number 4, use the Eustachian tube diagnostic questionnaire 7, tympanometry, and targeted endoscopic evaluation to track your outcomes. Number 5, and most importantly, protect the mucosa. Gentle surgical technique and respect for mucosal integrity in Eustachian tube interventions can change long-term outcomes. Dr. Tarabichi, thank you for sharing your insights about redefining anatomy with endoscopy and sharpening our decisions in chronic otitis media.
Thank you for having me here. It's always a pleasure. One of the things that I've noticed in my career is that interactions with people like yourself really teaches me a lot about clinical practice and opens up my mind to different ideas. So thank you again for having me.
Thank you very much.